Welcome to the Provincial Healthcare Violence Prevention Program, Module 3, the use of patient screening and alert systems. This PowerPoint module helps support the initiation of the screening process in our personal care homes. The literature supports patient risk screening at point of entry into the healthcare system. The primary purpose of patient risk screening and the use of alerts is to have a communication tool that assists healthcare workers in providing safe care and decreasing injury related to violence or responsive behaviors in patients. If you recall from our education sessions that we have put on previously that you had attended, our risk screening will also include times when residents who already live in our personal care homes are having reactive and aggressive type behaviors. There's more information that will be available in the attached guideline that discusses this as well. Some key learning points with this module is identifying risk factors associated with violent and responsive behaviors, using the template to screen patients, which I'll introduce you to shortly, activating and deactivating and communicating the alert status to all departments. Why risk screening and alerts? As you will recall, the Violence Prevention Program is new legislation in Manitoba. It's required by law. Legislation requires all employers to assess the risk of violence to staff. This is all about keeping us safe, as well as residents and families and visitors. We conduct patient screening at first point of contact to meet that requirement. So when we have a new resident moving into the care home, we're also including, as I mentioned in the previous slide, those residents who are already living in the care homes and are presenting with reactive and violent behaviors. Patient screening establishes a baseline of behaviors and risk factors. Why, again? So we're doing this because healthcare workers often report that the aggressive or violent behavior came out of the blue, and many of you can attest to this. However, research and investigations frequently reveal the patient had previous violent behaviors or was at risk for violence. However, behaviors were not reported, communicated, or flagged. With respect to our resident population, we have a lot of residents with dementia, and a lot of their behaviors may seem to come out of the blue. However, we know from our dementia care education and pieces that there's always an underlying cause that we need to figure out. Patient screening determines if an alert is needed. An alert prompts the development of a patient care plan / safe visit plan specific for violence prevention. As we recall, the purple and violet symbols of the intertwined rings refer to not only identifying a resident who is at risk for these types of behaviors, but also reminds us that we must use caution and respect every day when working with any individual. Screening is observational. Screenings are done by clinical staff. With respect to residents moving in, that will be completed by the nursing staff who are responsible for the admission criteria with the resident. It may be appropriate for staff in registration or intake workers to begin a process. These types of things will go on in other programs, and as mentioned in the previous violence prevention education that we shared in the past 6 months, different programs are using the risk screening on every individual. So even when we perhaps enter the emergency department for our own care, we're also being screened in the same type of way that we are going to be screening our residents. So that's just additional information for everybody. Final screening and determining outcome of alert status is the responsibility of the primary care provider. With respect to this, it's going to be a team approach in personal care. It's not one person making the decision. We all always get together and discuss situations with residents, as well as trying to mediate risk with behaviors and that sort of thing. So that process isn't going to look different. We're all going to get together and agree or disagree or work towards a plan of care that everyone can work with respect to screening and alerts as well. Resident risk screening and the use of alerts will occur at first point of contact. So with respect to our program, that may even be during the first family visit for a site tour. We will definitely have some information available once a new individual is paneled to move into our care homes. Definitely during the admission process, when new information becomes known, when an individual is transferred, discharged back to home care, for example, or going out on appointments even to other healthcare providers, as well when we don't know an alert status. We must always assess the patient and situation to determine if there is a risk of physical violence. Responding appropriately may prevent escalation and keep us safe. With respect to this, it's really not much different than what we've been doing already with our pieces framework that we work with. We know that we have residents who have responsive behaviors resulting from their illness, their dementia, and our role as caregivers has always been to put interventions in place to help not necessarily manage those behaviors, but prevent those behaviors from occurring, be it with our approach or certain care strategies, etc. So this isn't much different with respect to that. Patient risk screening tools. How do we do this? Risk screening tools look differently within the programs, the different programs in our region, depending on the population. Ours is quite different than that of acute care. However, all screening tools use the same process and follow the same 3 criteria, which are evidence of current violence, evidence of past violence, and current potential risk factors. This is an example of the risk screening tool, which you can access in the education package if you have it printed. It has all of those sections. Section A is there evidence of current violence or aggression. Section B, evidence of past or active violence or aggression. And C, current risk factors. So I'm just going to go a little more in depth with that in the next few slides. Important to note when the screening tool is completed, every section must have a response. Nothing is to be left blank. If, when completing a screening tool for a resident, there is no evidence of current violence or aggression, there is no evidence of past violence or aggression, and there is no current risk factors, then the box that states no evidence in those areas must be ticked off. Okay, we can't leave anything blank. Section A, is there evidence of current violence or aggression? So we want to be identifying these items. Has the resident been observed threatening violence, attempting or actually being violent, being aggressive to property, being aggressive to another individual? That may include those times when during personal care, and this is probably one of the most common times, where we're seeing residents who are very aggressive during those times, trying to protect themselves out of fear, where they might be biting and scratching and kicking, etc. And other situations as well, where maybe it's not related to an episode of care. That really needs to be identified in here. And then finally, if there is no evidence of current violence or aggression, make sure you tick off no evidence. Section B. Section B refers to past violence or aggression. as we as a region move further into the violence prevention screening in all programs, we're going to start seeing residents moving in who already have an alert either from home care or from hospital. So this would be an example of when you might see or might have that evidence that yes, there was past history. In addition, if until that process is fully evolved within the region, we may have information from other resources that help us identify that yes, this individual did have past episodes of violence or aggression. Okay, and again, when you're going through this screening tool, if there's no evidence of past, tick off no evidence. There is a section for additional comments related to screening and assessment outcome, not captured elsewhere. So any details that you need to add, okay, to help paint the whole picture of what's going on in this screen of the individual, add it there. Section C, with respect to the resident and potential violent behaviors, speaks to current risk factors for violence or aggression. Again, there is an area of no evidence, and ensure that at least one of these items is identified within Section C, same as Section B and A. So, what are some of the current risk factors that we might see? Confusion or disorientation, agitation or impulsiveness, anger and irritability, paranoia or suspicion, substance intoxication or withdrawal. And with respect to our residents in personal care, we might see these types of things with respect to medication changes. Okay, so not something to always keep in mind. Dementia with aggressive responsive behaviors would also be an obvious risk factor for violence or aggression, and that would easily go under other. Keep in mind that would have to be a physician or prescriber diagnosis. If there's no evidence of current risk factors for a resident, make sure no evidence is checked off. Risk factors in themselves do not always lead to violence. But early recognition of risk factors and implementing precautions is the key goal to prevent a violent incident from occurring. And this again is not much different than our focus when we're working with our residents from a PCH and dementia care point of view. We want to be proactive, and that's a little bit about what this screening tool is about. It's about being proactive in care and not always reactive after the fact. The alert is required when one of the criteria is met in Section A or B. Okay, so a positive criteria. If we're identifying that yes, there has been current violence and past violence, that would be, either of those would be criteria for an alert. Or the second situation, alert is required when two or more in Section C, excluding no evidence, is presented on the screening tool. So if we have an alert that has Section A and Section B showing no evidence, okay, the risk factors in themselves, depending on the situation, depending on the individual, might be enough to have an active alert initiated. It's always going to depend on the individual and the situation overall. If the screening tool outcome is alert not required, no further action. The screening tool must be filed on the resident's chart or health record as a part of the permanent patient record. Healthcare workers must communicate with all clinical and non-clinical staff by implementing the provincial alert symbol as per our program process. And you can refer to the guideline on this that's attached to the education and within our policies. Alert activation using the provincial alert symbol. Again, remember this purple and violet symbol alerts us to the fact that an individual has violent tendencies, reactive behaviors, and when we are engaging with anybody inside or outside of personal care episodes, we must always use care. We must always use caution and respect every day. The alert must include documentation on the care plans. This will vary between programs within our region, what that looks like. Please refer to the guideline on alert activation as to where the alert symbols are to be located and who is responsible for doing that. A positive patient screening prompts the healthcare worker to conduct further assessment. And this is within the nursing department. So when we have a positive screen on a resident who already lives with us, we're working together as a team to try and come up with strategies to prevent those violent behaviors from occurring, very much like a PCH assessment. Nothing new in our world with respect to that. If an alert has been activated, that patient care plan must be started to outline interventions to lessen the risks. Perhaps it's as simple as not walking up behind the individual because that startles them and they immediately escalate into violence. Those are the types of simple things that every staff member within the site, all departments, needs to know. The re-screening process will occur at various times. When we have a resident who is who has screened positive initially, and he or she has the alert status and the violence care plan, we don't want that label to follow them through their time with us, especially if their condition changes and their behaviors change and their response and aggression changes. So that's an example of when we may rescreen. It may be when, as requested, or at the discretion of the healthcare worker. So that would be a time when we're getting together to do care plan reviews, we notice changes, it's not a concern anymore. So again, we're working together as a team to decide if we should remove the alert on the individual. We're going to rescreen when violent or aggressive behaviors occur. With respect to this would be an individual who is currently, when they first were admitted, they were fine, there was nothing, and then something changes and we're starting to see violent or aggressive behaviors. That's an indication that, yes, we can do a screening even though the individual has been living with us for a period of time. The new guideline on managing aggressive and responsive behaviors in personal care helps move you through that process. We rescreen when new information becomes known. That could be information we're getting from home care, from hospital, from family after a resident has moved in. We're going to be rescreening an individual when risk factors are not identified on that initial screen but are present now. I've shared an example that fits that scope. And when there's a change in medical or other status or circumstance that indicates potential or actual violence may occur. So that's with respect to the risk factors and any other changes that we're seeing. With respect to the outcome of screening, if the resident's screening or reassessment reveals a continued risk of aggression or violence, we're going to be checking the box that says maintain alert on the screening tool and ensure the continuance of the alert is communicated. The person responsible for communication within the site can be found in the guidelines attached to this education and policy. As long as alert is active, communication tools such as logbooks, binders, and the symbol must be used. The decision to remove or maintain an alert is at the discretion of the primary care providers. With respect to personal care home, that's going to be a team approach. It's not one person that's going to make that decision. It's the nursing team. The decision is based on assessing if the behavior has been eliminated or mitigated. If so, the alert must be deactivated. The history of having the alert status remains on the resident's record. Any initial screen or rescreening and all the documentation associated with those two items are always a part of the resident's record and must be maintained. If rescreening reveals that the alert should be deactivated, this is the second screening, check off the box that says discontinue alert. So that's when we're deactivating the alert and removing all of the labels in all of the departments that previously identified that the individual was potentially a violence risk. Any of the situations where an alert is initiated, maintained, or discontinued will be identified not only on the screening tool, but within the resident's integrated progress notes. What about communication? Clinical handoff refers to those times when we are communicating and sharing information between healthcare members of the same team. So clinical handoff would be during those times when we are transferring information between shifts. When days is reporting using the intershift reporting to evenings, and evenings to nights, and nights to days, and that sort of thing. In addition, over and above the clinical handoff, because in personal care, our violence prevention alert status must be communicated to all departments. Those times are being shared in a different manner, and we're including any information to reduce the risk of violence to any member of the site. Disclosure is always on a need-to-know basis again, and limited information is shared depending on the situation, depending on the risk associated with non-clinical team members. Again, there's additional information on the clinical handoff and communication with the guidelines that are attached to this education as we move forward in implementing the screening process. When we are in a position to transfer a resident, say to home care, to hospital, out to another care provider, even for an appointment, we're sharing that information with the external care provider to ensure that they're prepared for any potential situation. This information is shared on the provincial transfer form, and logo would be attached. Again, those guidelines are within the policy that go along with this education. Questions with respect to PHIA. We had a lot of discussion around this at our violence prevention education over the past few months. So, first question, what can I tell other healthcare workers about the patient's alert status? Answer, with respect to the PowerPoint presentation, the answer is, share the individual's personal health information with any healthcare provider who has, is, or will be providing health care. Information shared must be on a need-to-know basis and the minimal amount needed to provide safe care. Now, within personal care home, it gets a little more confusing than just within the with respect to providing personal care. Our residents are freely mobile. Every single department, every single individual working within the sites at any time may have contact with a violent resident. So how do we share information? It's really going to depend on the situation. If we have a resident who displays responsive, aggressive, violent behaviors only during personal care, okay, only when our healthcare aides and our nurses are working directly with the resident, we don't need to share specific information about that with other departments. In general, yes, we share that the resident has violent tendencies. In that particular example, we might say it's only happening during personal care. The reason we want to be sharing that is to give other departments an understanding that the individual might be displaying reactive behaviors or reactive and violent behaviors. It's not necessarily a threat to them. However, at the same time, they're able to, in time, if they're seeing changes to the resident during their interactions with them outside of personal care, as an example, they can share that back with the nursing team, and we can further build a more robust care plan to support the resident. Another example is if the individual has just outbursts at any particular time, anything we've developed for the care plan to mediate that risk with this second example, all those details should be shared with any individual who might be approaching the resident. That information on the care plan must be shared. What about communicating with other residents, family, and visitors? They're going to ask about the alert symbol when they see it. If you recall back to the violence prevention education that we completed over the past several months, the basic response is simple. It should be, this person has a special care plan. Keep in mind that an alert status within the violence prevention program is considered personal health information and should be treated as such. We are not to share any personal health information outside of the realm of those individuals who should have access to a resident's care plan or information. This is the end of Module 3 on the use of screening and alerts in the personal care home. Please complete the quiz attached with this education and review the policies and guidelines that are available at the same time that this education is being shared. If you have any questions or concerns, please refer to your clinical team manager. Thank you and have a great day.